We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome to the new episode of A Pinch of Salt. I'm George Kosmadakis, a nephrologist from France, and I'm your today's host for a subject that is very interesting and very evolving. We talk about Avacopan in ANCA-Associated Vasculitis and in general the treatment of induction remission in ANCA-Associated Vasculitis. The successful treatment of anti-neutrophil cytoplasmic autoantibody-associated vasculitis focuses on suppressing the disease activity while minimizing treatment-related toxicity. Cyclophosphamide plus glucocorticoids was the standard therapy for induction of remission for nearly 4 decades. A series of randomized trials has promoted the use of rituximab plus steroids for remission induction as a relatively common standard of care in recent years. However, there remains an unmet need for additional agents. In the phase 3 Advocate randomized trial in patients suffering from granulomatosis with polyangiitis or microscopic polyangiitis, Avacopan, a selective oral C5a receptor antagonist, was non-inferior to prednisolone topper in achieving remission at week 26 and superior in sustaining remission at week 52. The role of this new treatment option, as well as other treatment options, is to be discussed today with our guest, Professor Lorraine Harper from the Division of Immunology and Infection, University of Birmingham, UK. Lorraine, welcome to the Pinch of Salt.
Thank you very much.
So we'll start with the first question, which is, what is new concerning the pathophysiology of ANCA-vasculitis, and are there any new players around?
So I think the biggest advance that we've had in the last 10 years has been understanding the role of complement in ANCA-vasculitis. So complement was previously not thought to be involved because particularly the lesions, when you look at the kidney biopsy, it was posse-immune, limited immunoglobulin deposition and complement deposition. But there was some really exciting animal studies done in Chapel Hill that investigated the role of complement depletion, complete complement depletion. These mice failed to develop vasculitis. And then further investigation showed that deficiency of factor B and C5 deficient mice were also completely protected from ANCA-vasculitis in the model where MPO ANCA was injected into these mice. If you blocked out C4, you still got disease, and that sort of indicated that it was the alternative pathway that was important in developing disease activity. And certainly there is evidence that C5a, which is the Avacopan obviously blocks C5a receptor, but C5a acts as an important chemotaxin for neutrophils, and C5a binding to neutrophils increases the expression of PR3 and MPO on the cell surface, so it acts as a neutrophil priming agent. It's important also that to note that C5a can activate platelets, and that drives further inflammation. So not only is it important in priming neutrophils, but it's also probably important in driving damage and inflammation locally. So complement, I think, is probably the most interesting development in understanding pathogenesis of ANCA disease. We know neutrophils are very important. B cells are obviously very important given the success of rituximab in treating patients. T cells continue to be important, but perhaps our understanding of their role is not as good as some of the other elements of the immune system. And we still have less understanding than what we would like around why immune intolerance develops in the first place.
Right. So the novelty concerning the pathophysiology is that we found that complement participation is very important.
Particularly the alternative pathway.
Particularly the
And we now
alternative.
have agents that can block that activity.
Right. And that C5a is an interesting target due to the fact that it's an agent that is facilitating the priming of neutrophils, and it also accentuates the pro-inflammatory activity.
Yeah.
So this is very interesting, and this is another edge in the post-rituximab era, if we might say. So this is a new player around. And I will pass to the next question. Which are the current options in the remission induction therapies for ANCA-Vasculitis?
So I think that we're still using cyclophosphamide or rituximab, although many places are moving towards rituximab as the primary immunosuppressant. And the important thing is what we use with cyclophosphamide and rituximab. And you talked about in your introduction about steroids being very important as adjuvants to those immunosuppressants. And that continues to be the case in many places, but we've now got the opportunity to use Avacopan as an alternative to steroids. Avacopan acts as a small molecule inhibitor of the C5a receptor. And by blocking that receptor, we know in animal models that blocking that receptor ameliorates disease. And the Advocate trial showed that there was benefit or there was equivalence at 6 months, non-inferiority, I should say. There was non-inferiority of Avacopan compared to glucocorticoids at 6 months in patients who were randomized in a trial of over 300 patients to either receive standard dose, reducing dose of steroids versus Avacopan. What happened at 6 months was in the trial design was that steroids were stopped at 6 months, but Avacopan was continued for 12 months. And in that trial, there was superiority of Avacopan over standard of care, which was the steroid taper at 6 months and then stopped. So maybe I should go back and explain the trial design. The way the trial was set up was that individuals were treated with either cyclophosphamide or rituximab induction therapy. They were randomized to receive either steroids or Avacopan. Steroids were reduced from a high to 0, and 0 was achieved by 6 months. Avacopan was continued for a year. There were 2 primary endpoints dependent on the results of the first primary endpoint, which was remission at 26 weeks. And if at that point there was non-inferiority achieved, they then went to look at superiority at 12 months. And indeed, Avacopan was superior to the standard of care limb at 12 months, suggesting that these individuals that Avacopan was at least as good as steroids up to 6 months, and then if you stop steroids, it was better than nothing. And I think that's an important that has to be acknowledged, that the superiority of Avacopan was compared to nothing versus steroids. But what it does tell us is that it can be used safely to induce remission and to maintain remission in the context of other immunosuppressants. Importantly, in that trial, there was much less toxicity in the Avacopan limb as you would compare to the steroid standard of care limb in terms of steroid toxicity. So there is a glucocorticoid toxicity index score, which was significantly lower. And then if you look at specific things like diabetes, etc., there was less incidence in the Avacopan limb. So Avacopan could be used safely with less side effects and at least as good, if not better, superiority in terms of efficacy over to a 12-month period. So I think that one of our sort of real drivers has been towards reducing steroids. And this is the first treatment that's allowed us to actually replace steroids. But, you know, Avacopan is expensive and it's not going to be available for everybody. And I think it's really important to note the recently published trials that have shown that lower doses of steroids are at least as effective as higher doses, if not safer, given the fact that the Pexivas trial, which was published in a few years ago, compared standard dose steroids with a lower dose regime in those with severe vasculitis, GFRs less than 50, or pulmonary hemorrhage. And in that study, the lower dose corticosteroid regime was as efficacious in terms of preventing death or end-stage renal failure, but had a lower incidence of severe infections. And then there was a further trial published from Japan, which was a trial was called LOVAS, which compared lower dose corticosteroids. It was almost half the dose in Pexivas, so starting at 0.5 milligrams per kilogram, compared to 1 milligram per kilogram regime. And again, in that study, the lower dose limb regime was just as efficacious in controlling disease, and again had a lower incidence of severe infections. It has to be noted, though, that in the LOVAS study, the type of patients that were recruited did not have as severe disease as in the Pexivas trial. So recommendations from the international guidelines now are that in those with severe disease, Pexivas lower dose regime should be used, whereas in those without life-threatening disease or organ-threatening disease, it is possible to use the LOVAS low dose, which is half the dose of the prednisolone. So I think that increasingly we are being more focused on toxicity associated with steroids, and lower dose steroids is certainly efficacious, but we have the alternative, which is Avacopan, to actually replace steroids.
Right. Well, I'm old enough to have experienced patients that were treated from their vasculitis, but we lost them from the treatment for vasculitis later on. And these protocols with lower doses of corticosteroids are validating the choices of the therapeutic community. And so if anybody has not the means to have Avacopan, which seems at least equally efficacious and safe, they can go for lower doses of corticosteroids.
I think it does have to be noted, however, that in the Advocate trial, the vast majority of patients did have some steroids up front. Right. So they had steroids either before they went into the trial or a short reducing course for the first few weeks after entry into the trial. So it wasn't completely steroid free, but obviously the Avacopan group received significantly less steroids than the control then.
Well, it's different. It's another discussion to give steroids for 2 weeks or for 6
Yes.
months. There is a
Yes.
huge difference, of course. Of course. Which are the future possible therapeutic options for ANCA-Vasculitis? You know, with this avalanche of new treatments for IgA nephropathy, all nephrologists are becoming really excited now, and they are searching for new agents for all the diseases, including ANCA-Vasculitis. Is there anything else in the pipeline?
So I think, like in IgA vasculitis, a lot of the new complement inhibitors are being thought about for ANCA vasculitis. So Avacopan, which is the factor B inhibitor. There's a phase 2 monoclonal antibody directed against, which is a monoclonal antibody directed against factor B, which also blocks the alternative pathway activation, so working slightly different from C5a. So C5a is blocking the chemotaxin and the effects on neutrophils and inflammation from that regard, whereas Avacopan and the monoclonal factor BB antibody is blocking actually the alternative pathway activation. There's advances on rituximab, so potentially obinutuzumab, which is the humanized version of rituximab. And then, of course, there's CAR T therapy for ANCA vasculitis, and there's lots of excitement about CAR T therapies, which are directed against CD19, which causes increased depletion of B cells compared to rituximab and other B cell depleting therapies. The CAR Ts are directed against CD19 as opposed to CD20. And that's interesting because CD19 has greater expression than CD20. So it sort of is able to target marrow B cells as well as plasmablasts. And those trials are in sort of very early setup phase or early development phase 2 at the moment. But obviously they come with their own challenges, because with CAR T therapies, you need bone marrow lymphoablation so that they can work. And that's difficult because it adds significant degrees of toxicity, which in a disease where we are reasonably good at treating patients now, it's going to mean that patient selection is going to be a challenge for CAR T therapy. You don't want to wait until the patient's at the end of the road in terms of therapeutic options, because they will have accumulated lots of damage, which then means that the side effects associated with CAR Ts are going to be really quite threatening. But then you don't want to treat patients who would easily be treated with things like rituximab. So I think that will be a challenge for CAR T therapies for the future. So patient selection, really important.
Patient selection, yeah. Probably CAR T will be saved for those with the most severe aggressive forms at early stages, I suppose.
Absolutely, yes.
Well, wonderful. We'll do another podcast next year for the CAR T therapies. Who knows?
That will be exciting.
Yeah, why not? So thank you very much, Lorraine. And now we'll get to the most difficult question, as you said before, which is the get to know you question we ask everybody here. And this is, if you were on a desert island, which book, 2 songs, and luxury item would you take with you?
Well, I'm a terribly, I like to read for relaxation, so I like a good thriller, and I would take the collections of Ian Rankin's Rebus series with me so that I could reread them and remember home.
Lorraine, me too. I have read everything. I am also a huge fan of Ian Rebus. I, I admit it. I have read everything.
It's
I
lovely. They're great
yeah.
books.
The new one just came a few weeks ago. So yeah, I am with you. What about the two songs?
See, I would need to take an album with me for relaxation rather than two songs. So Vivaldi's variations would be to relax me and to keep me calm while I'm worrying about being stuck.
Vivaldi's Variations,
The Four Seasons.
the Four Seasons.
Yeah.
Which one? Spring?
Yes.
And which one?
Oh,
Which is the second one?
probably has to be autumn.
Autumn, me too. And luxury item?
Oh, has to be my bubble bath.
Bubble bath. Thank you so much, Lorraine. Thank you. So, dear colleagues, corticoid avoiding therapies are significantly improving the clinical outcomes, security and safety profiles, and the quality of life in patients with ANCA-Associated Vasculitis. Avacopan, as well as other agents, are very promising in this immunological fine-tuning treatment option. More solutions, as you heard, are on the way for this challenging group of patients. Please stay tuned to our other podcasts available in all known digital platforms. Thank you.